Dear doctor, I am a lady aged 55. I'm diabetic and one of my eyes is not seeing things properly. My children bought me reading glasses, but my vision is getting worse. Other people are saying it might be due to the fact that I have diabetes, but they are also saying nothing can be done to help. Is there anything that can be done for my other eye, which is still seeing properly?
Diabetic retinopathy is a medical condition. It can also be surgical, but the cause of it is the diabetes mellitus. What happens is that when we have got diabetes, the sugar that is high in your blood system damages the blood vessels in your retina, in the eye. And what happens with those blood vessels is that they begin by narrowing, and then the cells that form the wall of those blood vessels, they die slowly. And when they die slowly, the wall of the blood vessel becomes weak, and then the blood vessels start ballooning and they start leaking. At the end of the day, they may bleed. And when that happens, it means blood flow to the retina is now affected. And when there's no blood flow, it means your retina is no longer getting enough oxygen. And when it's not getting enough oxygen, it starts dying. And we call that ischemia. Dying because there's no oxygen is called ischemia. And what your body does after that, it sends hormones that causes these blood vessels to start growing other blood vessels so that they can supply the areas where the oxygen is lacking. But those new blood vessels that form are also fragile, and they break and they bleed. So this is what will be happening, and your retina will be dying slowly and you become blind. There are two types of diabetic retinopathy. The first type is called a non-proliferative diabetic retinopathy. When we are saying non-proliferative, we mean that we don't have growth of those new vessels that I was talking about. So it's a non-proliferative diabetic retinopathy. And this one is graded into three. This first type is graded into three types. There's stage 1. Stage 1 is a mild disease with a little bit of convoluted blood vessels with aneurysms or dilatations, but it's not a problem. It doesn't cause any symptoms, and the patient won't know about it. It can only be seen by the doctor if an examination is done. Then stage 2 of non-proliferative diabetic retinopathy is a moderate disease where we now have abnormalities in blood flow in the retina. And then stage 3 is a bit worse, and here we have swelling of the retina, we have got exudates. These are certain substances that are produced by the cells. They go outside of the cells, they cause swelling, and we may have bleeding of the retina. So that is stage 3 of non-proliferative diabetic retinopathy. Then stage 4 is the severe disease. This is now the second type. It's called a proliferative diabetic retinopathy. This is where now, because the blood vessels are now damaged, you don't have enough oxygen in the retina, you now grow new vessels in order to supply those areas that are suffering from low oxygen. And this is what we call proliferation of blood vessels. So this is the proliferative stage, and this is severe retinal disease or severe diabetic retinopathy. So there are two types. So there's non-proliferative or proliferative. The problem with this disease is that in many patients, there are no warning signs. There's no early warning signs. Some patients may come presenting with fluctuating vision. Some, if the center of their eye called the macula, which is the one that sees fine stuff, is affected and is swollen, they have central visual loss. Whereas the others may actually come with the haziness of vision or total blindness because probably they have bled inside the eye. So there are no warning signs, but the moment the patients start complaining about poor vision and they're diabetic, sometimes it could be late because we don't have early warning signs. The first risk factor is duration. If you are diagnosed diabetic today, 20 years down the line, you are likely to get a retinopathy. And all people with type 1 diabetes, those with type 1 diabetes are the ones that inject themselves insulin. When they are 20 years with the disease, all of them, they will be having some form of diabetic retinopathy. Whereas those with type 2, after 20 years of disease of diabetes mellitus, they 80% only or 60% only may actually develop diabetic retinopathy. Age is also a factor. It's more common in those that are over 40. Those that are under 40, it's less common for them to have diabetic retinopathy. Those who have got poor sugar control for their diabetes are also at a higher risk. Those with the hypertension or high BPs, high blood pressures, and they are poorly controlled, they are also at a higher risk. Those with the high lipid levels, high cholesterol, and they are poorly controlled, they are also at a higher risk. Smoking is a risk. Those with kidney failure are also at a higher risk of developing retinopathy. Pregnancy is a predisposing factor. When you are pregnant, your sugar becomes very difficult to control sometimes, and you've got all these other hormones that interfere with your sugar control, and you become a high risk diabetic retinopathy potential. Being black is a risk. Being American is a risk. Being Hispanic is a risk. This is a retinopathy. It's damage to the retina. So the first thing that we will notice is, as a complication, is poor vision, because your eye is not working very well. The second, if you remember from when I described how it happens, is you get bleeding inside the eye, which we call vitreous hemorrhage. The third, because of the bleeding into the tissue or into the retina itself, that retina becomes thick and it becomes heavy, and it sort of discamates or falls off the wall of the eye and hangs inside the eyeball like a cloth. That is called the retinal detachment, and that happens with people who are diabetic. Then we also have glaucoma. Glaucoma is when the pressure inside the eye becomes too high, higher than it's supposed to be, and that is caused by the blood, those blood vessels, the new blood vessels that are trying to re-oxygenate those areas where blood is no longer reaching. So those new blood vessels, they will grow on areas where they are not supposed to grow, and they may grow on apertures that are responsible for draining waters in the eye, because the eye is a chamber. Water goes in with nutrients, and water with waste comes out. So at the outlet, the where water is supposed to come out, these vessels that are just growing in order to feed other areas where there is no feeding, they will grow in those areas and clog those areas. And then water is no longer moving out freely. Then you get high pressure inside the eye. It's called the rubeotic glaucoma. We may also have a blindness. That's the ultimate. the ultimate complication is blindness. And then we have other complications when somebody becomes blind. Then we have social complications, economic complications. Because if I become blind today, I will need a second person to pull me around. Whereas a person who has been blind from birth, they won't need somebody to pull them around because they know they've sharpened the other senses. Whereas myself, it will take me time to adjust. I'll be needing somebody to pull me around. So that's already a social compromise or a social problem to the family. And as far as the economy is concerned, it means I'm out of the job, I've become less productive. So you can see it's a barrage of complications, and it affects individuals, families, societies, and even nations. It's very simple. For us to diagnose diabetic retinopathy, the first thing when a patient comes in, we do the visual acuity. We want to check how good do they see. It's called visual acuity. That's number one. Then number two, we also want to check the pressure of their eye. Like I said, in diabetes, you may get the glaucoma or pressure going up. We want to check the pressure of their eye. Number three, we want to dilate their pupils so that they are wide enough so that we can see at the back, we can see the retina at the back of the eye, which we call fundoscopy. Then we can see those changes that I was talking about, that you can see the changes, the bleeding, the cotton wool spots, like the exudates, the swelling. We can see all those things with our eyes using some machines. We may also need to do fundus photography. These are pictures which we take with cameras, even cameras from the phone. There are some cameras from the phone that we can actually use to take those pictures, and on those pictures we can actually see the changes. We may also do what we call fluorescent angiography. This is where we inject a dye into the vein, and then that dye will reach the eye, and then we'll be taking pictures of our retina, and we'll be seeing that dye to see where it is going, where the blood vessels are compromised, where the blood vessels are not compromised. These days we have what we call an OCT. It's a tomography. It's like a scan of the eye, which takes slices of the retina, and you can actually see very well and make a diagnosis even before the eye can see the changes. This OCT scan can actually tell us the changes before the eye can see those changes. But in very late disease, we may end up needing to do ultrasound scan in order to see somebody probably has bled into the eye, somebody has got the retinal detachment I was talking about. An ultrasound scan can actually help us to see those. So these are the things that we do in order to make a diagnosis for diabetic retinopathy. There is medical treatment. When we say medical treatment, we mean we want your sugar to be controlled. And of late, people use, or doctors or the medical fraternity, they use insulin to control the sugar, or tablets to control the sugar. We also need to control our blood pressure using medications, and we also need to control our cholesterol using medications. When the patient now has diabetic retinopathy, we also sometimes use steroids or corticosteroids, which we inject into the eye, inside the eye, in order to ease out that swelling that will be happening. There are also newer medications called anti-VEGF. VEGF means vascular endothelial growth factor. Those new blood vessels that I told you grow willy-nilly and they cause problems. They are caused to grow by this vascular endothelial growth factors. So we have drugs that actually oppose that growth factor, that sort of fights, that antagonize that growth factor so that these vessels do not grow. And they are called anti-VEGFs. We also inject them in the eye, and then those new blood vessels that cause a problem, a nuisance, they do not grow. And this is how we manage it medically. Then surgically, when complications are there, or sometimes even before complications, we may need to do laser. So under surgical, there is laser treatment. In areas where there is bleeding and leaking of the blood vessels, you can actually laser that area or burn that area. You know, when you burn a bleeding vessel, it shrinks and then the bleeding stops, isn't it? So that's how we use laser in the eye to do that. But the area that you burn, that area dies when you're using laser. And then the second surgical option that is there, especially if somebody has bled, somebody has had a retinal detachment, or they have other problems which are as a result of the complication of diabetic retinopathy, we do what we call vitrectomy, where you operate, you put instruments inside the eye, and you scoop out all the jelly inside the eye. That jelly inside the eye called the vitreous. You scoop it out, and then you repair what you're supposed to be repairing. And then you either leave fluid or put a gas or put silicone oil in the eye in order for the eye to become okay. So we've got medical treatment and surgical treatment for diabetic retinopathy. It is preventable. We encourage people to remain fit, do a lot of exercises. And you know, when you are fit and healthy, sometimes even control of your sugar becomes better. Control of your lipids, your cholesterol becomes better. And also the good feeding habits, a lot of vegetables, fruits, and those will actually lead to better control of your sugar and your blood pressures and everything. You also need to have a strict control of your cholesterol, your sugar, and your blood pressures. Regular eye checkups, there's no substitution for that. You need to have regular eye checkups. You don't go to the doctor when you're already complaining of poor vision. Like I said, there's no early warning sign. The moment you start complaining of poor vision, you might be late. So a regular eye checkup is very important. So all diabetics are encouraged to have a regular eye checkup so that at least they are kept in the loop so that they don't develop diabetic retinopathy. There is also need to make sure that the glycosylated hemoglobin I was talking about is regularly checked, probably twice a year, in order to see if the control is good enough. If I do your glycosylated hemoglobin today and it's 6.5, which is good, maybe 6 months later I may need to repeat it to see what I was doing. Have I been controlling this sugar well for the past 3 to 6 months? I may need to repeat it. So that will give us an indication whether our sugar is being controlled properly or not. If it goes beyond 7%, you know we are not doing a good thing in terms of control of the sugar. We also need to encourage patients to pay special and strict attention to changes in their vision. If you are diabetic and you see changes in your vision, that's a cause for concern. You need to see your physician, and your physician needs to send you to an eye doctor as early as possible. Why? Because early intervention, if we come in early, then we can actually prevent the severe disease Like I told you, it goes by grade. If we catch you when you are early, we are likely to keep you at that early stage. If we fail to catch you when you are early and catch you when you are now late, it means you now need interventions that are expensive. Whereas when you are early, the interventions that we use will be less expensive. Like I said when I was talking about the complications, diabetes is a burden to the economies in many countries. Because as you know, diabetes is a chronic disease, and being a chronic disease, most patients get medications for free. In good countries, they just go and get medications for free. And in other countries where they have got national medical aid, that's what the patients rely on. Whereas in our setting, you can see our patients have been getting medication for free from government hospitals for diabetes. But at the moment, you realize that you may go to the hospital, but there's no medication. So they have to buy it from town. So the patients have no money to buy from town, and most of them are actually elderly. They are out of the job, they are not working, and some have actually been retired because of this diabetes and because of the blindness due to diabetic retinopathy. So you can see the economic burden that the nation is on because of diabetes. A lot of money, millions of money, go into trying to manage diabetes. Then as a social burden, if prevention could be made available to everyone, so that we've got less diabetic retinopathy patients coming in with blindness, then the social burden on families will become better, as you can see. In other countries, developed countries, screening for diabetic retinopathy is standard medical care. So each health center, they screen for diabetic retinopathy for all diabetics that they know, at least probably twice a year or once a year. So it's done there in developed countries. But as you know, in many places, like in our place, we have things that stop that from happening. These are called barriers. Education is one of them. Are our people aware of people who are walking around with diabetes? Granted, they don't know what we are talking about when we are saying diabetic retinopathy. The physician has not told them. The physician has not referred them to the eye doctor. So people are walking around with diabetes mellitus, but they don't know anything about diabetic retinopathy. They will only know it when they develop a complication. And they come to me, then I tell them you have diabetic retinopathy. That's when they will know it. So education is one of the things that we lack, and our physicians, our family physicians, they also need to gear up on that one. Availability of treatment is another problem. You may find that even if a patient has a complication, the doctor may tell them there's nothing we can do now. I've often seen many patients that come to me, they are being pulled, and the doctor has already told them nothing can be done. Yet, after we do something 3-4 months down the line, the patient can actually walk on their own. But they've been told already that nothing can be done. Why? Because sometimes even us doctors, we may not be knowing that some form of remedy is available in order to instruct our patients. And the other thing is infrastructure. Because if you look in our country, eye doctors are only in major towns. All small towns do not have eye doctors. Our patients are being looked after by general practitioners and by nurses. And that's on its own is a problem. Then we have waiting periods in other places where patients go, they are booked to come back in 3 months. Somebody is starting to have diabetic retinopathy today, they approach a health center. They are booked to come to be seen in 3 months. Diabetic retinopathy won't wait for those 3 months. It will be developing and becoming worse, isn't it? So those are problems. Then sometimes we don't have the tools to use. We don't have the tools to use as professionals. And also sometimes professionals ourselves, we lack the skills in order to help our patients. Need to intensify the education for the patients and for the population in general. We need to intensify also the training for the health personnel, especially in eye care, so that they know how to screen for diabetic retinopathy. I also want to encourage all people with diabetes. The moment you are diagnosed with diabetes, demand from your doctor to be referred to an eye center so that you will be screened. I also would want to encourage all our doctors to kindly be aware that once a diagnosis of diabetes mellitus is made, the patient now needs to go for eye screening, and that should be done regularly. So let's refer our patients for eye screening.